Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And today I'm joined by Dr. Daniel Hofer, a family physician and palliative medicine physician who specializes in community-based palliative medicine. He's developed something called the Transitions Program, which is offered through Sharp Healthcare in San Diego, California. Dr. Hofer, thank you so much for the presentation that you're about to give.
Thank you very much, Larry. Are you ready for me to get started?
You're on.
Great. So thank you, everybody. I appreciate you taking the time to listen to some presentations about geropalliative medicine. Today, I'm going to be talking about why geropalliative medicine needs to become mainstream for all specialties and for all of healthcare. We have a tremendously evolving healthcare system. And one of the problems for us as we move forward is the vastly growing body of advanced geriatric patients. And our need to understand these patients better is going to start not only from more medical evidence, but understanding the construct for which we practice care. So I have multiple disclosures because I am a consultant for multiple groups. However, none of this should influence the information that I am providing to you today. These are the objectives to understand the changing paradigm of geriatric medicine. We need to be able to understand the conflict between traditional management and newer evidence-based updated standards. There's always some conflict as we move forward. Demonstrate the importance of prognostication, especially for the high-risk elderly population. And every provider should be able to name at least 3 things that they could do in a traditional exam, a traditional physical, that they're not doing now that would improve outcomes for the advanced geriatric population. So here's the nuts and bolts of the question. What does a good outcome look like for an elderly geriatric patient when they come in to see you? Whether you're starting a medication, just sending them to the hospital for a pneumonia, or you're sending them for a surgery. What does a good outcome look like? And then while you're thinking about that, ask yourself this: why isn't there a standard definition for a good outcome? And if there is some definition, who do those current metrics cater to? Most people would say, of course, a good outcome from the patient's perspective is they want us as physicians to fix the problem they came to us for, but they also want to come out the way they went in. So they don't want to lose anything in the process of fixing the problem that we offered to treat. If you look at that from a traditional or palliative perspective, research would say, did the patient survive? Did they have a stroke, a MI? Did they have kidney damage, a GI bleed? What's the cost to the healthcare industry? But patients are saying, truly patient-centered care would say, will I live autonomously, not just did I survive? Will I be able to speak, walk, recognize my loved ones separate from a stroke? Did I lose my cognitive abilities? Will I be exhausted? Will I be in chronic pain, such as the chronic pain from chemotherapy, the neuropathic pain? Or will I be moved to an institution? And of course, patients and families are constantly, directly or indirectly, asking the question, what emotional and financial burden will I be to my family? So here's an example where we can look at that conflict. To this date, according to the American Heart Association and the American Medical Association, we still report Terri-Schiavo as a resuscitation success. Now, when we report Terri-Schiavo as a resuscitation success, which metrics are we referring to? It should be obvious to most people that we're referring to traditional metrics. And most people would say, well, of course, we know this, and that's why we explain to patients that if it's a witnessed arrest, you have a 5% chance of survival. If it's an unwitnessed arrest, it's 10%. The longer you wait to be resuscitated, the less your probability of survival. And the older you are, the worse those statistics become. But if that's the case, then why don't we just represent that information to our patients directly and say something such as the probability of a meaningful survival is 2%, or 1%, or less than 1%. Why don't we just say that up front? And the rest of the question would be, are we representing other information that we share with our patients in the exact same way? So if you look at these metrics, who do you think when we tell a patient there's a 5% chance of survival for a cardiac arrest, which metrics are we referring to? We're certainly not referring to the palliative metrics, although we address them. We're referring to the traditional metrics. What we learned from this case is that disease does not exist in isolation from other issues, from the family, from culture. And in fact, in the Terry Schiavo case, it became a national event that we talked about her and what would be the right thing to do. And we also know that historic metrics to define good outcomes are simply inadequate. They're not enough. And we need to move forward with better metrics to define good care among our patient population. And here's another example of feeding tubes. You think of feeding tubes, what's the metric we measured? We measured weight. We know that feeding tubes in the advanced elderly either do nothing or they increase pneumonias, they increase pressure ulcers. They do not improve the biochemical markers of malnutrition, and they increase suffering. In fact, the patient dies quicker. But the metrics we used was weight, although it didn't improve outcomes. And so it falsely deceived patients and ourselves, frankly, to believe that we were doing something beneficial for patients. We didn't understand that the machinery to metabolize nutrition was turning off, so it didn't matter that they were gaining weight. The weight gain was simply related to how much Jevity or Isocal we could stuff into their intestines. So if we're going to move forward with evaluating good care, patient-centered care, we have to expand our research metrics, and we have to eliminate metrics that do not improve value, do not provide value. We need to be sure we're giving full disclosure to our patients and families of the long-term effects and consequences of our care. And we need to use evidence-based knowledge. We can't just be guessing and saying, well, I think this is the case. We actually know the answers to many of these questions. There's other tough questions we need to ask as we move forward with updating the construct of responses to patients and their families. The first question, it's a little bit tough, is who are we treating? And I'm constantly asking that question of myself when I treat my patients. You know, am I doing this because this is just what I've been taught to do over the course of 3.5 decades of practicing healthcare? Or is there actually true benefit in this treatment for my patient? And have I given them full disclosure of the consequences? And that leads to another very difficult question in palliative medicine in particular, is how do we address the moral resolution and existential suffering of the family and healthcare providers? Providers feel like they have to do something in many cases, and to them, that intervention may actually cause more problems than benefits. And families associate a feeding tube with preventing starvation, but in fact, hand feeding has been proven to be better and more appropriate for these cases with better outcomes. So at Sharp, we have a expanded model of palliative medicine. It's a little bit complicated, but I'll walk you through this, and this will help you understand how primary care can work into this model. We have post-hospice, if you go all the way to the right, bereavement for the family. We have hospice care. We have inpatient and outpatient community-based palliative medicine, but we've moved palliative medicine upstream. And just as we have with pediatrics, we use anticipatory guidance to guide our patients and their families in the aging process and the consequences of our care. And when you start to realize that there's more to healthcare as patients age and you need to distinguish patients at risk, it becomes much more important to develop that professional skill of anticipatory guidance. So our goal ultimately should be to anticipate and guide our patients and families and the unintended consequences of well-intended care, because we're really good at discussing the good consequences, but we're not really good yet at discussing and identifying who's at risk for the unintended consequences. This is probably one of the most important slides I can share with you today, and that is the historic perspective of healthcare. You know, historically, our patients got to a point, we used to call pneumonia the old man's friend. The patient would die. Diseases, when they occurred, frequently led to the patient's demise. But nowadays, virtually every disease we're taking care of, we can manage so well, we're finishing the bell curve. And what we haven't done in healthcare is to look at that red circle and say, you know, how well are we at managing this particular demographic? And I'm going to read something to you to help you understand what I'm talking about. I think most people are aware of the SPRINT study that came out in 2017 talking about blood pressure for our patients. But about the same time, there was an article published in the Journal of the American Geriatric Society. It was called Knowledge Gaps in Cardiovascular Care for Older Adults, a scientific statement from the American Heart Association, the American College of Cardiology, and the American Geriatric Society. This is an executive summary. And it says the incidence and prevalence of most cardiovascular disease increases with age. And cardiovascular disease is the leading cause of death and major disability in persons aged 75 years of age and older. Despite the effects of cardiovascular disease on quality of life, morbidity, and mortality in older adults, individuals aged 75 and older have been markedly underrepresented in most major cardiovascular trials. And virtually all trials have excluded older adults with complex comorbidities, significant physical or cognitive disability, frailty, or residents in assisted living and nursing homes. As a result, current guidelines are unable to provide evidence-based recommendations on the diagnosis and treatment of older adults typical of those that we encounter in routine clinical practice. I want to be sure you heard that. Patients age 75 for cardiovascular care, according to the American Heart Association, are not evidence-based in the care we provide. And that's because we deliberately excluded all those people in the red circle from research. And then after excluding them, we extrapolated the results back upon them and said, hey, well, it must be equally applicable. And what we're finding is that that is not the case. This group is called the advanced elderly, and that's the demographics that's growing the fastest in this country. I want to read one other part of that abstract that's particularly important. A pervasive lack of evidence to guide clinical decision-making in older adults with cardiovascular disease was found, as well as a paucity of data on the effects of diagnostic and therapeutic interventions on outcomes that are particularly important for older adults, such as quality of life, physical function, and the maintenance of independence. And it goes on to talk about cognitive damage. Those issues are critically important for our advanced elderly. And we need to start looking at our advanced elderly differently than just another patient, but we need to learn how to stage them just as we did with our younger pediatric patients. In fact, when I was trained in pediatrics, if you treated a newborn like an adolescent just because they were both pediatric patients, you would have lost your license. Well, we need to start developing the same attitude for managing the advanced elderly population, because these people have lost their physiologic and cognitive reserves. And every time we do something to them, we accelerate the geriatric syndrome or functional decline pattern or cognitive decline pattern that puts them at risk for worse outcomes. So what do you need to do when you move forward looking at these patients? Well, you need to look at 6 areas. Number 1, you need to look at general information, disease burden, medications and lifestyle, their functional patterns, their ADLs, their falls, their timed up and go tests, cognitive status. We should be doing cognitive evaluation on these patients routinely. And we need to look at geriatric syndromes to define their risk. And why do we need to do this evaluation? Because of the simple fact that uninformed treatment is mistreatment and overtreatment can be deadly. So I put this slide in. That's me off on the left. My wife is from Thailand and she goes to the local Buddhist temple. The monks have asked me to be their physician, but I put this slide in to remind myself that in Buddhism there is a moral principle, and it exists in virtually every religion and ethical standard that I am aware of. The Buddhists call it the principle of right speech, and it certainly applies to healthcare. That you have a moral obligation to share information with your patients, even if it would lead them to a decision that is contradictory to what you would have chosen, and you need to share that information in a timely manner and as kindly as possible. So, for example, the time to tell your patient that they could have permanent cognitive damage from their hip replacement is not when they're being wheeled into the OR. It should be done weeks before they hit the hospital so they can sit down and have a value statement with themselves and their families about the risk of proceeding with the intervention. So that's my soapbox. I'm going to translate that all now into practical medical care. So this is a patient of mine. She's given permission to use her photograph. The case was actually about 6 years ago. This is a picture of her from last year. And here's her story. At the time, she was an 80-year-old female, spinal stenosis, came to your office with low back pain with radicular symptoms. She had moved in with her daughter to manage her IADL. She'd actually been living with her son prior to that. Otherwise, she's independent in all of her ADLs, but she bathes twice per week and uses a shower chair. What's that mean? That means she's not actually independent in all of her ADL. She's starting to have ADL decline as well. She's fallen twice in the last 6 months, and she does not meet phenotypic criteria for frailty. She hasn't lost any weight. She's active, and she gets out of the house and would do a lot more if she had help. Her daughter states she's just not as strong as she used to be and cannot open jars. She uses her handrails to pull herself up upstairs and now for balance. That's her previous medical history: COPD, heart failure, moderate depression, insomnia, and osteoarthritis. These are her medications, and those are her vital signs. The exam's normal except for a little bit of temporal muscle wasting, decreased grip strength, mildly decreased air exchange, no rales, ronchi, or wheezing. Her cardiac exam is normal. There's no edema. No neurologic deficits except for a foot drop. She has a normal CBC, CMP, and her cholesterol is 232. Her chest x-ray is clear, her EKG is normal sinus rhythm, her timed up and go test is 19 seconds, and her MMSE is 23. The daughter comes in with the mother and states that her mother's life would be better if she just didn't, quote, have sciatica. She'd been in the hospital because of the fall for the foot drop. As well, the patient was just in that hospital for that foot drop and told you that she was told that she, quote, must have surgery. She asked you specifically about surgery and states she's heard bad things about opioids. Non-surgical interventions have otherwise had limited benefit. So what can you tell them about the consequences of going for surgery at this age? What do you see in this patient's presentation that has raised a significant amount of warning signs that this is the patient is not going to have a good outcome? What are her unique risks? And we need to be thinking about this for every single patient using those 6 criteria. So I remind you that the 6 risk domains define that patient's risk, and this needs to be integrated in what we do on a regular basis. We know she's older. She's being treated for depression. I have to tell you right now, I made a couple of adjustments to this presentation just for educational points. She has polypharmacy. She doesn't drink or smoke. She has functional decline. She has cognitive decline. She does not have any significant disease burden as of yet, no pressure ulcers, no biomarkers we would consider poor. Her Charlson comorbidity score is not particularly high. And the question, of course, is does she have any geriatric syndromes? And the answer is she does have a geriatric syndrome in addition to her other evaluation. She's developing sarcopenia. Sarcopenia is incredibly common in the advanced elderly population, and the studies put it at 50% for some research. Sarcopenia is not the same as cachexia, and it is not the same as frailty. It's an independent prognostic geriatric syndrome and defining risk for our patients. 20 to 50% of our patients the age of 80 and older will have sarcopenia, so it's extremely common, yet rarely diagnosed. And when a research article or a physician says, well, this patient has a 5% chance of stroke, heart attack, or some other negative outcome from this intervention, these patients are that 5%. And this is why we need to be so aware of these different geriatric syndromes defining patients' care. So this is sarcopenia. This is what happens over time. Starting at about the age of 30, we lose about ½ a pound of muscle per year. We gain about a pound of fat. Most of us know that as we're getting older, we have to work harder to keep our weight under control. You are physiologically losing muscle and gaining fat. That's a change in your body fat to lean body ratio. What many people are not aware of yet is that your adipose tissue, your fat tissue, is secreting pro-inflammatory cytokines, and your muscles are secreting anti-inflammatory cytokines. And this ratio of pro and anti-inflammatory cytokines is mediating the physiologic changes that determine your risk. One way to measure sarcopenia is to look at the iliopsoas muscle, and it's particularly important, and you can screen for this as well. The iliopsoas muscle is a main hip flexor. It also is the muscle that helps your patients get out of bed. So simply by asking them, do you have a hard time leaning forward and getting out of bed, or has your walking speed slowed down, or have you had any falls, or do you have any ADL deficiencies that are related to this particular structure, then you can start to have an idea that this patient may have sarcopenia. Otherwise, you need to do a DEXA scan and or a CAT scan to do iliopsoas measurements. But particularly important because if you don't know this when you send that patient to surgery, they could have bad outcomes. So what do we know in medical evidence with sarcopenia? That these patients will have more infections, pressure ulcers, loss of autonomy over time or after hospitalization, institutionalization rates go up. They will have worse quality of life post-hospitalization, and they have higher mortality with the exact same procedure that an otherwise equally symptomatic or equally phenotypic patient would have, but without sarcopenia. For this particular patient, you could look up the research and say sarcopenia and thoracolumbar surgery shows this patient will be in the hospital about twice as long. He will have 300% more hospital complications, and she's almost guaranteed to be institutionalized after the procedure. Now, that was particularly concerning to this patient because she was happy at the age of 80, now 86, furniture surfing around her home because all she wanted out of life was to be able to interact with her grandchildren and her children and be there as their grandmother, participating in their lives and their stories about their lives. There's other prognostic information you could have gotten from this patient's story. She has IADL deficiency. She has the beginnings of decreased cognition, although some of that may be medication induced. She is a little bit older. And if you look at a very crude but older prognostic model, this patient has about a 55% chance of having some form of functional decline after hospitalization. Now, we can't tell you whether her timed up and go test will get worse. We can't tell you whether she'll get weaker. We can't tell you whether she'll develop urinary incontinence. But what you can tell them is that even if we fix your spine, in some other area, you're going to have some level of functional decline, more likely than not. You could look at issues such as the timed up and go test. And I will tell you that the American College of Surgeons uses a timed up and go test of 15 seconds to decide that the patient is at risk. And if it's under 15 seconds, they're not at risk. The original research said 10 seconds or less is normal, 10 to 20 seconds is borderline, above 20 seconds, these patients are at great risk. But just by knowing timed up and go test, functional dependence, she has IADL deficiency in her falls, these predict this patient will be institutionalized after her hospitalization. And then you can go out and add, layer on that the research that actually validates that. There's an inverse correlation with walking speed and her polypharmacy. So it can't be surprising that this patient has a slowed walking speed. That's statistically known. Even if she came into the hospital as an emergency case, you could look at her polypharmacy and ask questions about her walking speed and functional performance just because she's on so many medications. So if you look at her medications and lifestyle, the medication issue which puts her at the greatest risk for hospital-induced delirium is functional decline, and the answer to both of those questions is polypharmacy. Polypharmacy in the elderly is an iatrogenic disease that's causing significant harm. Their physiology is changing, and we need to be aware of that. We cannot be cavalier about piling on medications for these patients, and we're going to talk more about their physiology of the geriatric patient later on. So this patient also has dementia, or the early signs of dementia. And a lot of people would recognize that people with MMSEs of 23, we don't really pick those up in our offices very well because we're in a rush, we're talking to these patients, they can still answer questions, but if you do a more in-depth evaluation, you'll realize that these patients are at risk and they can lose their functional and cognitive abilities by being given a body insult by an intervention or a hospitalization or a procedure that might stress their cognitive abilities. So if this patient did decide to go to surgery, and I can tell you that she and I talked for some time, and we talked about the risks, and we talked with her family, and she decided it wasn't worth it. She would rather just stay on her hydrocodone 3 times a day and use her AFO to walk, and because that provided her the functional status that she wanted for her life. But what if she did decide to go to surgery? What would you do? And you may do some of this anyways. You would decrease her polypharmacy. There's many things we could have done in that list to lower her number of medications. We would decrease her anticholinergic burden score, and we'll be talking about that when we talk about delirium. We would send her for prehabilitation, meaning that we have studies that showed when these patients are exercising before surgery, they do better. We would increase protein in her diet, and we'd do many other things that we're not doing routinely now to improve her outcomes. We would consider melatonin for sleep, but also for delirium prevention. That's off-label, but there's research articles that show that melatonin protects the cognition of the elderly patient when they go to the hospital for surgery. We could also consider using perioperative antipsychotics. That is also off-label. And there's a great debate going on, and I can tell you that the American Geriatric Society has not taken sides on this at this time. They're not for or against it, but some meta-analyses have shown that patients actually benefit from perioperative antipsychotics to prevent delirium, and we'll be talking about delirium and its association with dementia in later presentations. So one other thing that we would do is we'd be sure that the patient and family were aware of the patient-centered unintended consequences. So yes, we can fix your spine, or yes, we can fix your heart or your hip, but at this age, there may be some unintended consequences that might make the value of this procedure less than optimal. It's up to you. So I do want to tell you that the patient did not go for surgery, and she has been doing great since that time. In fact, that picture I showed you was from a year ago. And she came in that day, and I asked her, well, what happened to your AFO, your foot orthotic? And she told me, oh, well, my foot drop went away, and my pain's pretty much perfectly controlled with 3-hydrocodone. So we went from a visit where the patient was told she had to have surgery more than once to a full discussion of the consequences of surgery, and the patient's been living a beautiful life since that time without surgery, living life in the value system that was important to her. So I'm going to give you one more case study. This is an 83-year-old male, severely frail, declining health, comes to your office with severe pedal edema, cognitively intact, and is able to move from room to room with the front wheel walker. Echocardiogram showed moderately severe aortic stenosis. He's referred to cardiology for a possible procedure. He sleeps in a recliner to help him breathe easier. Those were his medical problems. You can see his medications. His BMI is 21, but he has severe pedal edema, and he's getting over a stage 3 sacral ulcer. His laboratories are all normal, but he just came back with a total cholesterol of 68, and he is cachectic appearing. And I tell you that this is the story of my father, because I had to tell my family what his physicians weren't telling him. It's not that they were malicious, they just didn't know this information. But my first question to you about my father, and I want you to look at these 3 pictures, is in which picture is my father frail? In which of these pictures? There's only one correct answer. I'll let you think about that for a second. And the answer is this. Under no circumstances can you know if a patient is frail by just looking at them. You must do a proper phenotypic, preferably, or an index evaluation. No guessing. You can't look at somebody and know they're frail. In fact, that middle picture, my father could have been ambulatory and getting out. He just lost some weight and it was appearing more cachectic, but he was actually very active. In fact, he was phenotypically frail in every single one of those pictures, according to the Fried-Hopkins phenotype. And in the Fried-Hopkins phenotype, you have to have lost weight, you have to have lost muscle strength, and he had just gotten a personal trainer because he realized in the picture on the left that he was losing his muscle strength. I'll go back to you. You can look at these. He stopped going out. You can see that's the wing of an airplane. My father was a commanding officer in the Navy and flew for United. That was the last flight he ever took. Every time he went out, it made him exhausted. His activity level dropped at home, and his walking speed slowed down. My mother would tell me, well, we used to walk together down our walking path, and now he sits on the bench and I catch him on the back way and we go home. So he had virtually every characteristic of a patient with phenotypic frailty. And the fact that his muscle weight, his weight hasn't changed, but he was developing more edema was suggesting that his lean body mass was dropping. Now the picture in the middle is when my father was getting ready for surgery, and you'll see how that plays into this story. This is the picture on the right is after his intervention. So my father gets a palliative consultation from you and asks, what are the risks of surgery or medical management? What would you tell him? You use the 6 criteria. My father was older and male. He had an incident sacral ulcer, which is particularly concerning in the elderly. He had a comorbidity score, Charlson comorbidity score of 7 due to his age. He had problems with polypharmacy, and that could have been improved. He was cognitively intact, and that's a problem because that confuses people a lot. When somebody's cognitively intact and they can communicate things very clearly, we think everything's just fine, but we need to do the professional evaluation. His functional status was wiped out. He had complete IADL and ADL dependence except for feeding. And he wasn't even able to do a timed up and go test. He had 5 out of 5 phenotypic frailty criteria. So he was at extremely high risk of cognitive and functional decline and mortality because he'd lost his physiologic reserve. So I want to tell you the story before I look at this, you look at this slide. So I try not to be my family's physician, but I went up to my father's house. He lives about 72 miles up from where I live in San Diego. We were sitting in the backyard and he had shorts on, and I looked at him and I said, hey, Dad, you know, you got a lot of swelling on your legs. You know, maybe you should go talk to your doctors to see if there's something they can do to get some of that swelling off your legs. And he went to his internist, who immediately referred him to a cardiologist because after his echocardiogram, he had moderately severe aortic stenosis. So instead of just prescribing some diuretics, he'd already been seen by his cardiologist. So a couple of weeks later, when I drove back up, all of this had occurred, and I asked my dad, well, in the context of your frailty syndrome, what did the cardiologist tell you? And my dad, who was always very clear, he was a commanding officer, he was a captain for United Airlines for over 35 years, he couldn't answer my question. So I asked permission to call his cardiologist. He let me do so. We talked for half an hour. He's a very nice gentleman. But twice I asked the cardiologist, in the context of my father's geriatric frailty syndrome, what do the outcomes look like? And he couldn't answer the question. I drove down to San Diego. I called one of my favorite cardiologists in my medical group. Exact same thing. No clear response. So I want to show you what the literature shows. And then we can decide if that's enough to make a good decision. So this is the outcomes from TAVR for a patient who is frail versus non-frail patients going for surgery. And you can see for the most part that the 30-day mortality, bleeding issues, major vascular complications, kidney injury, stroke, except for mortality, there's no serious or significant clinical significantly different outcomes for this patient. But what's wrong with this research article from 2012, not that long ago? What's wrong with this research article? Brand new treatment, this new TAVR procedure, but what's wrong with the research? The research is, it doesn't include patient-centered quality metrics. We didn't include the issues that are most important to the patient, maintaining his general functional ability and maintaining his cognition. And so it raises the question, is that are we presenting information any differently to our patients now in modern research than the way we present a cardiac arrest? Yes, we can fix your heart, but what about the rest of you? Go back. Where are the patient-centered quality outcomes? They're not there. We are concerned in research about historic metrics. And yes, those historic metrics are important, but those historic metrics are not enough to manage our advanced elderly population. And it is incumbent upon us to start looking at those patient-centered outcomes. I find it particularly interesting that in the healthcare industry, we will perseverate about a patient's hemoglobin dropping from, say, 13 down to 9, or the creatinine going up from 1 to 2, which the patient doesn't even feel. But we don't evaluate whether a patient's MMSE goes from 27 down to 19 or 17. We don't even look at that. And we don't do non-stroke functional evaluations on our patients to determine whether we've actually accelerated their functional decline. And that needs to become a standard of care in the healthcare industry. So I would argue that the loss of cognition and functional status are the two most important issues for patients, and that's been validated in many research articles. That leads to patients' autonomy. So it's not enough anymore to simply fix the organ system. We have to be looking at the issues that are particularly important to patients, as was quoted in that article I told you from the American Heart Association, that we have to look at issues that patients care about most, their cognition and functional ability. So I'm going to make a quick statement. What happened with my father? And what happened with my father is that I had to sit down with my family and explain to them that there was risks that they were going to occur with this procedure, that although their doctors seemed to be very kind and caring, had not been explained to them. And I sat down with my dad, my mom, my brothers. I got my sister on the phone, and I said, these are the unintended consequences of well-intended care. What they're telling you is true, but it's not the whole story. My father decided to go for surgery. That's okay. But that proactive discussion about risk and what to do to lower his risk did not occur until I did it. I would like to point out something else that's particularly important. It's impossible to tell my father that the procedure didn't actually kill him quicker. Because if you look at the mortality rates for naturally evolving aortic stenosis, moderately severe to severe, the 2-year mortality rate's about 20 to 40%. But the 2-year mortality rate for delirium is about 40 to 60%. And I'm going to tell you what happened to my father after his procedure. And just to show you this, CAVR patients, about 25% of them will develop delirium from the procedure, 25%, 1 in 4. That's extremely important because mortality with delirium is extremely high. So the moral resolution for providers that if we don't understand or recognize the patient-centered concept of care, how can we advise against patient care? And one of the things I continue to hear in healthcare is, and many of you probably have, I've done this for 34 years, well, Dr. Hofer, if we don't do something, the patient will be dead in a year. The problem is that if we do something, the patient's quality of life could be a fate worse than death. And the other problem is it's possible that the patient will die more quickly by our actions. When we have frail patients, we have to recognize that these frail patients are sitting at the edge of a cliff. And they are with basically any geriatric syndrome. It doesn't matter whether you push them over the cliff with a major procedure or a minor intervention. The results are the same. They do not have the physiologic or cognitive reserve to tolerate the intervention. So I'm going to tell you the rest of the story about what happened with my father. My father listened to what I had to say. My mother was appreciative. He balanced the issues and said, I want to take the risk. He was a risk taker. I'm fine with that. He went to his cardiologist, and they didn't even do a TAVR, they did a valvuloplasty. And the valvuloplasty went beautifully. His aortic gradient improved, his ejection fraction improved, all of the fluid came off of his legs, and you could see, you didn't have to be a professional to know that he was frail. He was tissue paper skin on bones. His lungs, we did a thoracentesis and took a liter of fluid off of his lungs. We gave him his epigen, and his hemoglobin went from 9.4 to 10.6. And as predicted by prognostic modeling, he had significant functional decline and became a 2-person assist from wheelchair to bed for the rest of his life. He previously had been able to walk from the room, so even though the metrics for his heart were working perfectly, he was functionally declined after the procedure. To make matters worse, he developed severe delirium. And he was so delirious for the first 2 months, he didn't recognize anybody, and he was put on hospice. He died about 9 months later and never completely recovered his cognition. He couldn't focus. There were times when he was lucid, but he wasn't the person he was before. He was sleeping more hours, and he was hallucinating and delusional at night as a consequence of the procedure. So I'm asking you this as a son now, not as a physician. I happen to be a physician, but I'm asking as a son. Would medical research report my father as a perfect outcome? Go back and look at the research article. The answer is yes. But as a son, my father was not even half the man he was prior to that intervention. If you want to go back and look at those pictures, that was pretty much the way he spent the rest of his life, with his head down, with oxygen, not being able to communicate with the family. Some of the times he would just sit there saying, "I'm listening," and other times he was asleep. Did we do my father a favor? And that's how we have to look at our future care for our advanced geriatric population. So I'm taking this quote from Hippocratic physicians, but I think it's incredibly powerful because we've lost the skill of professional prognostication. And let me read the citation. It's an excellent thing for physicians to cultivate prognosis, for by foreseeing and telling the present, the past, and the future, and explaining the omissions for which patients have been guilty of, he or she will be more readily believed to be acquainted with the circumstances of the sick, so that men and women will have the confidence to entrust themselves to such a physician. And how much information are we omitting and our patients omitting when we make clinical decisions to guide our patients in their care? So that's Atul Gawande on the left. That's me on the right. I would encourage everybody to read his book, Being Mortal. However, I did suggest to Dr. Gawande that next time he writes a book, he needs to talk about the also acceptable pathway of not having any surgeries whatsoever. And if you want to read another book, it's by Katie Butler. It talks about the art of dying well. I wish she had titled that The Art of Living Well Until You Die, but this is how to keep the quality of your life up and making different decisions as you approach the last few years of your life. Just to give you some more information to have in your pocket, this is a research article published just 6 years ago looking at frailty and cardiac outcomes. The hospital mortality for general cardiac outcomes is twice as high. 1-year mortality is about 50%, 48, almost 50% of patients, so patients should know that no matter what you do. Higher adverse outcomes, higher dependence in function in survivors, almost 71%. That's extremely high. Readmission rates are higher, significantly worse quality of life metrics by standard quality of life testing if you operate on a frail patient. So geropalliative evaluations is something we need to integrate. And what this does for you is to put your care into context. It's not just about treating the heart, it's about treating the human being and the heart, or the hip, or the pneumonia, or the treatment, whatever it is that we're treating. So with that, I say thank you very much. That's first lecture in a series of lectures to discuss geropalliative medicine, and I hope that was informative. Please reach out to me at any time, daniel.hofer@sharp.com. Thank you again.